Hey, friends. So, something that I noticed is I bought a copy of a Kindle version copy. It was about $10, I think, of Fancy's book last year, Fancy Masale from the Good Waves Network. And the main reason I bought it was because in the Kindle preview, I saw multiple spelling errors right off the bat. So I wanted to review and roast it a bit. However, something I realized is we've been going kind of back to the beginning, back to the basics, reading over the Stan Hancock case file, the original messages between Gypsy and Aaliyah, all that type of thing, in addition to these emails. And in the book, Fancy shared a bunch of medical records from before Katrina. So, since I own the book, I have paid her for use of these and will be reading them to y'all. Now, for those of you who may not know about the great feud of January, Fancy tried to get my channel taken down with copyright strikes because she was mad about me roasting and reviewing her. So I am not going to show these on screen. However, I will have a link in the description to Amber's Google Drive, and they're available to review in there. So you can click on that link if you want to read along with me. Otherwise, you can just listen and we will go back to the words of the doctors and kind of compare those to the story that we heard later from Gypsy, Melissa Moore, Lifetime, and all the Blanchard clan. So the very first thing that comes up is a list that was made, typed up by Dee Dee that she would take with her to different appointments and stuff like that. It says Gypsy Rose's medicines. Some of these I won't be able to pronounce. Some of the medicines, conditions, and everything, y'all are going to be way more knowledgeable about than me, but I will do my best, y'all. Okay, something to note here is there's a sticker off to the side of a date stamp. It's March 14th, 2007. So this was entered into record after they were already living in Aurora, Missouri post Katrina. They hadn't got their habitat house yet. And Gypsy's age has been lowered because her date of birth is 7/27/1993, when it should be 91, as her age is 13. Medicines are Tegretol, 100 milligrams, 3 tabs 3 times a day, Zantac, 8.6 milligrams 2 times a day, Ciprodex, 4 drops in ears 2 times a day, Advair discs, 250-50, 2 puffs 2 times a day, fluticasone propionate, 2 puffs 2 times a day, SMZ-TMP 200-40, SUS 7.5 milliliters 2 times a day, diazepam 2 milligrams 1 to 2 tabs as needed, Proventil 1 to 2 puffs every 2 hours, lactulose 1 to 2 tablespoons every 6 hours as needed, Pulmacork 1 vial every 4 hours as needed, Zaponex 1 vial daily as needed, albuterol inhaler as needed. Last 4/24/06, 1400. So that really sounds like a lot. However, we know from the pictures of the medicine cabinet that it doesn't look like these were actually being administered on that sort of regular basis, or there wouldn't have been likely so many stockpiled up. What do y'all think, friends? And then next is a list. It says Gypsy Rose's surgeries: eye muscle surgery 4 times, Nissan fundoplication, PE tubes, that'd be ear tubes 3 times, which I personally on my second set right now. One of them's come out. I'll have to get a third. Muscle biopsy, upper right leg, submandibular bilateral gland surgery, tonsils, G tube placement, polyps, Botox injections, and salivary glands, dental, 4 years old. And the next one is Gypsy Rose's diagnosis: epilepsy, vision impaired, hearing impaired, GI reflux, quadriplegia, paralyzed, muscular dystrophy, anemia, hypoventilation, asthma, allergies, mild mental retardation, age 7, leukemia, incontinence, lung disease, and heart murmur. And someone was wondering a while back why diapers would be on hand or whenever in that one video where we were talking about Gypsy saying whenever she got her period, her mom's it said, "Get one of your diapers." I guess the incontinence would be why. We don't know if she's actually incontinent or if it was a training issue. Okay, and then it goes to a record. It says Tulane University Hospital and Clinic, New Orleans, Louisiana. The run date 4/18/07. So this would have been sent from Tulane to Springfield. So I don't really know where the whole, our medical records got washed away in Katrina. I don't know how Didi got by with saying that so much whenever they were having medical records transferred. So this record is from January 31st, 2001. It says the doctor is Robert A. Gordon, patient Gypsy Blanchard. Specimen muscle biopsy right thigh. Clinical history has a question mark. Neuromuscular pathology. Description of specimen. A piece of skeletal muscle was snap frozen and cryostat sections were stained with H&E, modified gamma trichome, acid phosphatase, PAS, NACH, SDH, AT PAS, pH 9.4, 4.6, and 4.2, and COX. Microscopic description. The sections show skeletal muscle cut on transverse planes. The blood vessels are normal. There is no fatty infiltration. Nerve twitch are not present. The paramesial and endomesial connective tissue are normal. There is no inflammatory reaction in the specimen. The muscle fibers are slightly irregular in size. Angular and rectangular atrophic fibers are seen and are predominantly type 17. Or maybe that's a I7. It looks like a 17. I'm not sure. Anyone who's reading along, let me know in the comments what you think that is. There is a type 17 fiber predominance. There is no grouping of fiber types. There is a normal number of internal nuclei. The nuclei are not vacuolated. There is no evidence of degenerating, regenerating, split, moth-eaten, or ragged red fiber. There is no evidence of vacuolation, targetoids, tubular aggregates, nemeline rods, rimmed vacuoles, central cores. Oh man. Eosphenophilia inclusions or reducing bodies. There are no other abnormal hydroarchiterical changes. Diagnosis: type 2 fiber atrophy. Comment: 9-year-old female patient with muscle weakness. The histological and histochemical findings suggest disuse, CNS lesions, etc. Clinical correlation is suggested. I wish I understood more about what that means. Let's Google type 2 fiber atrophy real quick. Okay, without going too deep, a quick Google says type 2 fiber muscle atrophy is often caused by aging, prolonged inactivity, or disuse. Chronic illnesses like cancer and heart failure, metabolic disorders such as diabetes, and certain neurological conditions. Steroid therapy and systemic stress from critical illness can also lead to this type of muscle loss. The underlying mechanism often involves decreased protein synthesis and/or increased protein degradation. Interesting, friends. I'm going to Google real quick how to fix type 2 fiber atrophy. To address type 2 fiber atrophy, focus on resistance exercise training, which is proven to be effective for rebuilding muscle mass and strength by stimulating muscle hypertrophy. That's interesting, friends. What do y'all think? The next one is still Tulane University in New Orleans. Says diagnostic study, visit date October 31st, 2000. Electromyography. Summary: nerve conduction study of both extremities, including latent responses, were within normal limits. BMG as above. Impression: no electrophysiologic evidence of neuropathy, radiculopathy, or myopathy. Again, y'all, I'm sure I'm butchering these medical pronunciations. Probably not the best person to be to this, but I thought it would be interesting to just try and understand as much as we can. And the next one, still at Tulane, it says operative report, procedure date, January 31st, 2001. Preoperative diagnosis, myopathy, operation, open muscle biopsy vastus lateralis. Postoperative diagnosis, myopathy, anesthesia, general endotracheal anesthesia. Estimated blood loss, none, less than 5 cc for the orthopedic procedure. Tourniquet, none. Findings, muscle. It did not look terribly myopathic. It had the usual nice red coloration in it. This submitted for quick freezing with liquid nitrogen. Procedure. Include inclusions, finding technique, closure, and condition upon leaving operating. After induction of general endotracheal anesthesia, the patient had an ophthalmologic procedure, which will be dictated as a separate operative report by Dr. Gordon. The patient completing that was turned over to orthopedics, where the right lower extremity was thoroughly prepped and draped. Intravenous antibiotics prophylactics being given. The patient had an incision made over the vastus lateralis. Dissection was carried down sharply through skin, subcutaneous tissues through the epithelium of vastus lateralis, and a muscle portion was removed, measuring approximately 1 centimeter times approximately zero point 0.5 centimeters. It was also in depth of about 1 centimeter. This muscle specimen removed, it was immediately placed on a saline-coated Tefla in a petri dish and brought down to the laboratory where I had walked previously to alert them. Liquid nitrogen immediately available, and the muscle was frozen for histologic examination and enzyme analysis and other things that neuropathologists do to muscle biopsies and myopathy. During this time, my assistant, Dr. Morgan, was closing the muscle, and going back, the muscle was closed. Subcutaneous tissue was closed. The skin was closed. A dressing applied under my supervision, and it was beautifully done. The patient had a dressing applied. The patient was awakened and taken to the recovery room in satisfactory condition, having suffered no known complications from this portion of the orthopedic procedure. Then it also has a run date of 4/18/07, where this was sent to Springfield. So again, like I always say, I have no medical training, so I'm not someone who can really interpret this stuff. I'm just doing quick Googles and giving my surmisings. Okay, this next one says operative report, date 1/31/2001. So this is going to be the second procedure they were talking about that was done the same day. Preoperative diagnosis, esotropia, dissociated vertical deviation. No clue what that means. Procedure. Include incision, findings, technique, closure, and condition upon leaving operating suite. After risks and benefit of the procedure was explained to patient and family, including risks of bleeding, pain, infection, scarring, need for further surgery, loss of vision, loss of eye, and anesthesia risk, the patient was brought to the operating room for procedure. The patient was prepped and draped in a sterile fashion after she underwent general anesthesia. The procedure was preceded with first of all the right lateral rectus muscle resection. Initially, the limbal paratomy of the lateral side of the right eye was performed using sharp Westcott scissors. Westcott scissors were used to bluntly dissect underneath subconjunctival and subtenons space to expose the bare sclerae. The muscle hook was used to identify the lateral rectus muscle. After homeostasis was achieved, a double-armed bioabsorbable 6-0 suture was placed 1 millimeter posterior to the muscle insertion on both sides of the muscle belly. Scissors were used to cut the muscle at the original insertion. Caliper was placed at 5.5 millimeters posterior to the original insertion and marked. The muscle was then reattached to the new insertion at 5.5 millimeters posterior to the original insertion. Hemostasis was achieved, and the conjunctiva was closed with 6.0 plain gut suture. The next part of the procedure included the right medial rectus muscle advancement. Of note is that the patient had had previous right medial rectus resection at the age of 3 years. A limbal paracony was performed in the medial aspect of the right eye. The right medial rectus was identified using muscle hook. The muscle was identified at 10 millimeter posterior to the limbus. There was some fibrotic tissue from the muscle insertion to the original insertion. A double-armed bioabsorbable 6-0 suture was placed at the two ends of the muscle belly, 1 millimeter posterior to the current insertion. A 15 barred Parker blade was used to detach the muscle from the insertion. Caliper was placed at 6.5 millimeters posterior to the limbus and marked. The muscle was again reattached to the new insertion of 6.5 millimeter posterior to the limbus. Of note is for both sides, lateral rectus and medial rectus, the muscles were placed inferior to the original insertion infraplacement to correct for the dissociated vertical deviation. The conjunctive over the medial rectus muscle was closed using a 6-0 plain gut suture. Hemostasis was achieved all through the procedure. Mastisol ointment was applied to the right eye. The patient and family were instructed to follow up with Dr. Gordon 24 hours after the surgery at the eye clinic. The patient and family were instructed to use the Mastisol ointment to the right eye, BID times 5 days. So again, I am definitely not someone who understands all the words that I just attempted badly. I apologize, y'all. Attempted badly to read, but it doesn't sound to me like these people were doing a procedure based on Dee Dee's say so. They very well documented exactly what they were doing and why, from the sound of it to me. If any of y'all have medical knowledge and have any reason to suspect something that I'm not having the knowledge to see in what I just read, please let me know in the comments. And then we have another one from Tulane University. It still has Gypsy's correct date of birth, 7/27/91, correct spelling. There's no E on the end of Blanchard. Interestingly, it says Gypsy A. Blanchard. There's no Rose in it. And the admission date for this one is April 25th, 2005, so a few months before Katrina. It says informant, patient, and her mother, reason for visit, follow up after hospitalization for cough. Interval history. Gypsy is a 13-year-old young lady. I saw her in my clinic in May 2004. Gypsy has a history of muscular dystrophy of unknown etiology, which is profound. She is wheelchair bound. She also has a history of moderate persistent asthma, chronic rhinitis, for which I follow her. In addition, she has a history of hypoventilation and apnea during sleep. She was followed for those problems by Drs. Simakajabrun in a pediatric sleep disorders clinic and uses CPAP at home to manage that problem. Gypsy was in her usual state of health until 1 week ago. At that time, she developed a cough and some associated shortness of breath and low-grade temperature. She was seen in the emergency department over Children's Hospital and treated as an outpatient with Orapred and Zyrtec. She came to Tulane Emergency Department the following day because of persistence of the cough. The cough was dry and non-productive and was associated with nasal stuffiness. She had a small amount of mucus that she was coughing up as well. During her hospitalization here at Tulane, she was treated with intravenous fluids and inhaled bronchodilators. She continued on the Orapred and Zyrtec and also had a 5-day course of Zithromax prescribed. Studies here at Tulane included serum electrolytes, which initially showed a slightly low potassium. This was normal on the subsequent recheck. Complete blood count, a differential, was essentially normal. A chest x-ray was done, which showed no acute changes. She improved and was discharged to home. And a follow-up appointment was scheduled with me, although I did not see her in the hospital. Since discharge, Gypsy has continued to improve. She now has a very mild to minimal cough. She reports some nasal congestion and rhinorrhea, but less postnasal drip than she had been having. Gypsy and her mother told me that her asthma has been fairly mild and well controlled over the past year. She typically uses albuterol by metered dose inhaler once or twice per week for mild flare-ups of wheezing or shortness of breath. She occasionally uses Zopinex when her wheezing is somewhat worse, but has not had to do that very much over the past year. She has had no other hospitalization since her visit with me last May for asthma or cough. And then it lists her current medications. There's 8 of them. Ativar, 1 puff twice daily, Flonase, 1 spray each nostril once a day, albuterol inhaler, 2 puffs every 4 hours when needed, Zopinex, 1.25 milligram nebulized every 6 to 8 hours when needed for wheezing and when unresponsive to albuterol. Zyrtec, 10 milligrams once daily when needed for rhinitis symptoms, Tegretol for seizure disorder, lactulose for constipation, Bactrim for urinary tract infection prophylaxis. So again, this description and the medications really don't quite sound that crazy. That's a lot of inhalers, but they're mostly as needed and with instructions of only use this if the other one's not working, not controlling the symptoms kind of thing. What do y'all think, friends? Am I misreading or missing anything in here? I don't know what a lot of those other medications were, like the Zopinex and stuff like that. It says it's nebulized for wheezing when they're unresponsive to albuterol, but that was a new one I'd never heard of. And this next page seems to be a continuation of of what we were just reading. It says respiratory therapy. Gypsy uses CPAP of 5 while sleeping overnight to support her nocturnal ventilation. Physical examinations, vital signs, temperature 36.4, pulse 78, blood pressure 108 over 70, and weight 37.1 kilogram. General, she is awake, alert, active, and in no acute distress. She was sitting on the examining table and cooperative with the examination. Head, ears, nose, and throat. She has mild to moderate nasal congestion and reduced nasal airflow. No polyps were seen. Mouth, teeth, gums, and posterior pharynx were normal. Tympanic membranes are normal. Eyes, the sclerae and conjunctivae are clear. Neck, supple, no masses are noted. Chest, the shape is normal. Palpitation and percussion are normal. Lungs, osculation is normal. Heart, osculation is normal. Extremities, peripheral pulses, and capillary refill is normal. Impression, mild to moderate persistent asthma, perennial rhinitis with seasonal flare. It appears that Gypsy has probably been suffering from a mild seasonal exacerbation of her rhinitis and asthma. Plan. I would like her to continue with the Atavir on a daily basis to control her asthma with intermittent use of the albuterol by inhaler or Xopenex by nebulizer to relieve the acute wheezing, cough, and chest congestion. I would like her to continue the Flonase 1 to 2 sprays each nostril daily to control her rhinitis. I think she will need to use 2 sprays daily during the spring months since it seems like that is the time when she has more problems with her allergies. We provided refill prescriptions to the above medications. She should continue her other medications as prescribed by her specialists and primary care physicians. I would like to see Gypsy back for a follow-up appointment in 3 to 4 months. And it lists her address again as Slidell, Louisiana. The next one's from Tulane, near time, April 20th, 2005. Chief complaint, constant coughing, history of present illness. I was asked by Dr. Nashab to come and see Gypsy after he discussed her care with Dr. Narong. Together, they have decided that Gypsy should be admitted. Gypsy had been in her usual state of health up until this past weekend. She began developing some cough on Saturday and Sunday. This cough worsened as she began to complain of some shortness of breath on Monday morning. She had a low grade temperature of 101.1 early Monday morning. Gypsy and her mother were staying at the local Ronald McDonald house, and they had a ride from there to the children's hospital. So they went to the emergency room there. At the children's emergency department, Gypsy was given a breathing treatment, Orapred and Benadryl. She was given a script for Orapred and Zyrtec and sent home on Orapred 2 teaspoons once daily and Zyrtec 2 teaspoons once daily. Ms. Blanchard reports that since yesterday, Gypsy's cough has become almost continuous. The cough is mostly dry. She has some nasal stuffiness and nasal sniffing, but not that much. She has had no fever since that noted above on early Monday morning. This morning, upon awakening, Gypsy coughed up a small amount of mucus with some blood-tinged secretion. Since that time, she has produced no more septum. Because of sputum. Because of this, her mother elected to bring her to the emergency room here for further evaluations. So that's interesting. That might be where some of the confusion comes in on the Ronald McDonald house because they were there a few months before Katrina. And I'm curious as we continue through these records if we'll see them there more around the actual time of Katrina. Review of symptoms. Constitutional. Decreased appetite, no fever other than that noted above. ENT, no headaches, no ear pain. She has some sore throat, but that began after the coughing started. Cardiovascular, no palpitations. She did have a murmur started at birth. GI, she has previously been diagnosed with gastroesophageal reflux and has had a Nissan fundoplication, age 7 years, and is still on medications for reflux. She had a G button placed when she was younger as she began to have difficulty eating. She occasionally has some incontinence of stool. Endocrine. Oh, so that explains the diapers, I guess, Jill? I don't know if that's just reported from Dee Dee or if they were able to observe that during a hospital stay at some point. That's not clear in this narrative, in my opinion. If y'all read it differently, let me know. Endocrine, no diabetes or thyroid problems. CNS, she had seizures in the past and is currently on Tegretol. The last seizures were approximately 2 weeks ago. She usually has 1 grand mal seizure every 4 to 6 weeks. They are usually short duration, lasted 60 seconds, and stop spontaneously. Her medications were increased in January because of seizure frequency had increased. She is followed by Dr. Afric. Musculoskeletal, she has formal muscular dystrophy. She is not ambulatory, but is able to get around in wheelchair. She is able to roll with her arms. However, her mother thinks that she is weakening in her upper extremity. Renal, she is often incontinent of urine. She has vascular Vesicoureteral reflux by history and is followed by Dr. Ottenberg at Children's. I had to Google what that last big word was that I struggled to say, and I still don't know if I'm saying it right. Again, if I'm mispronouncing all this, y'all, I apologize. Vesicoureteral reflux. I Googled that, and it says a condition in which urine flows retrograde or backward from the bladder into one or both ureters and then to the renal calyx or kidneys. So, with them saying this and that she sees a specific doctor for it, I wonder if that was actually verified by a test or study in some way. Interesting, interesting. Okay, this continues on. Children's Hospital. She has had intermittent urine infection. The last one was 4 to 5 months ago. She has had anemia in the past, derm only diaper rashes, allergies, felt to be allergic to cow's milk. Mother seemed to agree with her. However, she is on Pediasure at the present time. That's interesting because that's something that we've all been confused about because I didn't know about Pediasure, but y'all let me know in the comments that that does have some sort of milk in it, and they seem to be acknowledging the contradiction here. As they said, Gypsy feels to be allergic to cow's milk. Mother seems to agree. However, she is on Pediasure. And that's interesting because that doesn't all come from Dee Dee there. We know from the casebook, Stan Hancock's casebook, and Nick's interrogation and Gypsy's that she said whenever her and Nick went to the Waffle House after the murder, like a day or two after the murder, that she forgot she's allergic to milk and drank some and got really sick. So it's so confusing, y'all. There's so many layers here. Okay, diet history. Soft diet by mouth. She received 4 cans of Pediasure at night via her G tube. Birth history, born at term. Mom was on Seconal, secondary to preterm labor. Birth weight was 6 pounds, 2 ounces. Growth and development. She has significant neurodevelopmental delay, but currently attending homeschooling with second grade level. Immunizations up to date. Family history. Gypsy lives with her 30-year-old mother. Father was a drug abuser, according to mom, and he is not involved in Gypsy's care. Oh man, I would have thought way back before Gypsy got out that that was something Dee Dee was exaggerating. We know now that from Rod and Christy that it really wasn't. Social history. Gypsy is going to school. She is registered through Brock Elementary School. She has a number of activities. That's interesting because they just said above that, currently attending homeschooling. I guess they mean she's going to school registered and doing it homeschooling. Hospitalizations. Last hospitalization was several years ago. Surgical history. Nissan fundoplication, gastrostomy tube, thigh muscle surgery, tonsillectomy, and andoidectomy. So we got 5 before Katrina. I think there was only maybe less than 5 more. Correct me if I'm wrong, y'all. It says sleep study performed in August of 2004 was abnormal. She was on CPAP of 5. I know other people with more medical knowledge than me have already pointed this out, but you can't really fake a sleep study. So, and that's something I've also pointed out before is her grandpa talked in that one show about how she would have to be on the machine at night. When she would stop breathing, the alarm would start going off like crazy and they'd have to wake her up to get her to breathing again. And he remembered how scary it was and the alarm would go off. Well, that alarm wouldn't just go off if this was all fake. You know what I mean, friends? What do y'all think? Physical examination, vital signs, temperature 98.4, pulse 112, respirations 20, and blood pressure 128/71. Oxygen saturation 100% on room air. General, well nourished, well developed appearing young lady was lying quietly on the gurney. She had frequently dry hacking cough and also frequent nasal sniffing. Hair is shaved. Huh. Okay. So looks like the hair was getting shaved before Katrina. Eyes' pupils are equal and reactive to light. No scleral icterus or injection. Nose, small amounts of clear to white nasal discharge in the left nostril. No polyps, no nasal flaring, mouth and throat. The incision was fairly good. Examination of the posterior pharynx revealed small amount of white mucoid discharge. Next, supple without endinopathy. Chest, normal shape, no retraction, some breast development, lungs, good breath, sounds at all lung segments, no cackles or wheezes. Heart rate and rhythm, normal. Normal S1 and S2, grade 2 5, soft vibratory systolic ejection murmur at the left sternal border. Pulses are equal and bilateral. Huh, okay. So the heart murmur thing wasn't something Dee Dee just made up. They confirmed it through a test there, it sounds like. Am I reading that right, friends? Abdomen soft, good bowel sounds. G button is present in the left upper quadrant. Estonia site has a small amount of dry blood around the stoma, but otherwise looks good. Extremities, no clubbing, cyanosis, or edems. Derm, no rashes. Investigation, blood work was obtained during the emergency room visit. A PCO2 was 38 with normal pH. Comprehensive metabolic panel showed normal electrolytes except for a low potassium of 3.0. Urinalysis was negative except for moderate bacteria. Leukolite esterase is negative, as was the nitrates. Hemoglobin was 13.6 with the hematocrit of 41%. White blood cell count was 11,600 with 67% neutrophils, 33% lymphocytes, and 9% monocytes. Chest x-ray was obtained that I've reviewed it. Chest x-ray on PA film was some very good inspiratory film down to the 10th and 11th rib posteriorly. Heart size is normal. There is no silhouette signs of the heart, no effusion, diaphragm, and leaflets were well. Outlined in the PA film, on the lateral film, there is no evidence of retrosternal air and the diaphragms were not flattened. Impression: 1, constant cough, probably related to postnasal drip and viral and or bacterial infections. The former is most likely. 2, hypokalemia. 3, muscular dystrophy. Plan: admit for IV fluids, continue home medications, including Tegretol. Continue Orapred and Zyrtec is started by emergency room doctor. Throat was such as chloroseptic, slight decreased cough urge. Afrin 1 to 2 sprays each nostril daily. Hold nighttime feedings tonight. May have soft food by mouth. IV fluids with maintenance overnight. We will hold off on starting antibiotics today. We will reassess in the morning. It's so funny. You can see all through her medical records, they talk about different foods that she's has the whole time during that she has the G tube. So it's so freaking hilarious for her and Melissa Moore to try and pretend like prison was her first taste of real food. At the end of that ER description that goes over the same stuff again, it says final diagnosis: 1, URI; 2, pneumonia; 3, hypokalemia; 4, dehydration; 5, muscular dystrophy. Hypokalemia is low potassium. I just Googled that. The muscular dystrophy in this one, I think they're going by Dee Dee's word. But we saw those fiber tests earlier on, so very interesting, y'all. I'm curious for somebody who knows more about it than me to give their opinion on this fiber test. Well, this next one appears to be related to her salivary glands. It says the admit date is January 4th, 2005. So again, same year as Katrina, just the beginning of the year. So it's history and indication for operation. The patient is a 13-year-old white female who has a history of neuromuscular disorder not otherwise specified for which she is wheelchair bound. She has a history of hypersalivation and difficulty on her secretion, as well as a history of recurrent otitis media, which has failed multiple medical treatments. Interestingly, otitis media is kind of similar to my ear problem. It's related to blocked ears for which you have to have ear tubes. Okay, back to reading the actual narrative. She has had PE tubes placed in the past, and one PE tube has been extruded. However, it was in the right external auditory canal. However, the patient did not tolerate attempted removal in the office. Due to the planned procedure, it was decided that we would remove that while the patient was asleep. The procedure of Botox injections of the salivary glands the patient has had in the past as well, so the option for bringing the patient to the OR to place bilateral T tubes and inject her salivary glands with Botox was discussed with her mother. The risks, benefits, indications, complications, and alternatives were discussed with the mother, who wished to proceed with the operation and understood all of the above. The consents were reviewed, signed, and witnessed in clinic, and the patient was pre op. Now, that part was kind of funny to me whenever it says that one of the tubes has been extruded. That means it's no longer in the hole that they make in the eardrum. It's come out of that and it's just kind of sitting inside the ear. It's not hard to get out. Just need to dig it out. But it said that she did not tolerate attempted removal in the office. I wonder how she acted, y'all. Preoperative diagnosis: chronic otitis media with effusion and hypersalivation. Postoperative diagnosis: chronic otitis media with effusion, hypersalivation. Name of operation: bilateral my myringotomy tubes using T tubes, Botox injection of the salivary glands. Medications administered: Floxin otic drops, Botox total of 200 units. Findings: both ears dry. Procedure in detail: the patient was brought to the operating room, placed in the supine position, general mask anesthesia was administered, microscope was used to visualize the right tympanic membrane, which appeared to be normal. A migratotomy incision was made in the anterior interior quadrant, and the T tube was placed in the middle ear, placed through the myringotomy incision. Floxinotic drops and cotton ball were placed in the external auditory canal. Attention was turned to the left ear, which was visualized using the microscope and appeared to be normal. Myringotomy incision was made in the anterior inferior quadrant, and again, the middle ear was found to be dry. A T-tube was placed through the myringotomy incision, and floxinotic drops and a cotton ball was placed in the external auditory canal. At this point, an EMG machine was brought in, and EMG sensor pads were placed appropriately on the patient's face, and 200 units of Botox was drawn up for the lot number. And then 50 units was placed in each of the right and left submandibular glands, and another 50 units was placed in each of the right and left parotid glands using EMG guidance to assure that the muscles would not be injected, just the non-muscular gland tissue was injected. At this point, the patient was awakened and returned to recovery in good condition. There were no complications. All counts were correct. Dr. Wisdom was present for and participated in the entire procedure. Okay, we have quite a bit more to go through, but I'm going to go ahead and cut off here and edit. This morning, Feline come by again, so I was able to get some more footage of her out there. And something kind of funny is there's a squirrel that's hanging around our mineral block, but it ran off whenever it saw Feline. It was hilarious, friends. Anyway, let me know what you all think of this in the comments. If anyone knows more information about what I read and wants to add anything to it, let me know. Have a good